Thanks for joining us on Not Boring CEs, where we don't think you should be bored to death while getting your continuing ed. Keep listening here, then hop over to notboringces.com to get all your online CE credits. All right, y'all, let's get to learning. Kate Dancy, MSW, LCSWC, is a therapist in Rockville, Maryland, who specializes in working with children, adolescents, and adults with eating disorders, including ARFID, binge eating disorder, bulimia, OSFED, and anorexia, as well as obsessive compulsive disorder and self-injury. Kate can see clients virtually for therapy in Maryland, Virginia, and Washington, D.C. Kate has experience working in a variety of settings, including outpatient therapy centers, an eating disorder treatment center, partial hospitalization programs, and an inpatient program. Kate has a certificate in dialectical behavioral therapy through Behavioral Tech. She's completed training in dialectical behavior therapy for adolescents. Additionally, she's completed training in the treatment of anorexia, bulimia, and binge eating disorder. She's trained in exposure and response prevention for the treatment of obsessive compulsive disorder through the Center for the Treatment and Study of Anxiety at the University of Pennsylvania. Additionally, she received training on body-focused repetitive behaviors through the TLC Foundation for BFRB. She is an active member of various organizations, including the International Obsessive Compulsive Disorder Foundation, the Greater Washington Society for Clinical Social Work, and the National Association of Social Workers. Kate has been interviewed by Psych Central and was a featured contributing expert to the book Thrive, Expert Tips for Coping with Depression and an Eating Disorder. She wrote a guest essay as a featured expert for the book The Inside Scoop on Eating Disorder Recovery, Advice from Two Therapists Who Have Been There. In addition to therapy, Kate is a Maryland board-approved supervisor and offers clinical supervision to therapists wanting more training in treating eating disorders and/or OCD. Welcome, Kate. Let's get into this. Welcome to Not Boring CEs. I'm your host, Allison Pereer. I'm here with Kate Dancy, and we are going to be talking about the intersection of eating disorder and diabetes. And I'm excited to have this conversation as an eating disorder therapist. I remember a million years ago when I was working in residential, we would often have folks with diabetes and an eating disorder in the clinic. And there was very little I knew about that. And I honestly didn't get a lot of great training around it because it wasn't seen as my job. And now I think about how unprepared I was later when I went into outpatient, to be able to know when to refer, know how often to talk to their doctor, know all those kinds of things. So I'm excited to dive into this because there's also this whole other world of like diabetes medication that's being used to fuel eating disorders. So yeah, a lot to talk about. So thank you.
Absolutely. Yeah. Thank you so much for having me. I'm excited to talk about all this.
Yeah. Well, can we first start, because I think we'd be remiss to not address the myths about diabetes that I think
Absolutely.
it'd be good to clear that up before we get too deep into this conversation.
Yeah, absolutely. I think that's a great place to start. I also, if it's okay, I also wanted to talk a little bit about how I got so interested in this topic.
Yes, I would love that.
Okay, beautiful.
Let's start there.
Great. So I'm a licensed clinical social worker, and I'm in private practice, and I have kind of a dual specialty where I treat eating disorders and obsessive compulsive disorder. And I am very open about this, and I really like to share that I'm also personally recovered from an eating disorder. And when I was pregnant with my daughter in 2012, I developed gestational diabetes, which is really quite common and very manageable. And then slowly over time, I started to have more and more difficulties with energy and just like fatigue and a couple different things. And I went to the doctor and actually got diagnosed with type 2 diabetes myself. And as I started to research, what I needed to do, I really saw how much kind of fat phobia and kind of diet culture has infiltrated the diabetes care kind of field. So that's one reason why I think this is super, super important to talk about. But yeah, so going straight into talking a little bit more about myths, one of the biggest myths is that only people in larger bodies get diabetes. This is, it's just really not true. Many people in smaller bodies develop diabetes, and many people in larger bodies don't develop diabetes. So that's one really big myth that I think is out there.
Absolutely.
Another myth is that Diabetes develops when you eat too much sugar, right? And so, like, a lot of people have this understanding, and I've actually even heard about like school systems or workplaces having like a diabetes awareness week, and their activity for diabetes awareness week is to like take the sugar out of to move the candy bowl away or whatever. And so it just sort of speaks to like how limited people's knowledge is about it.
Yeah.
So what causes diabetes is there's really a myriad of factors, but one of the biggest risk factors is a family history of diabetes. So like naturally, there's a big genetic component. Another risk factor is having polycystic ovarian syndrome, which is another very, very common thing that people deal with. And then also having had gestational diabetes is a big risk factor. So something like, I want to say 40%, I'd have to check my numbers on that. But it's a very high percentage of people that have gestational diabetes that will go on to develop type 2 diabetes. So there's many, many risk factors.
Right.
And really this idea that like, eating sugar is what causes diabetes, it's just not true.
Right. And I think about how that's perpetuated through things like jokes.
Mhm.
Like, oh, got
Mhm.
this box of donuts, just diabetes waiting to happen. Like that kind of vibe that
Right.
I like we'll see in comedy shows sometimes, or just like people cracking bad jokes, like walking around that I don't know how that got rooted as the cause, but it really is in a lot of people like that combination of if you're fat and you're eating sugar, then you must have diabetes or you're about to.
Right. Exactly.
And
Exactly.
can we talk about the word fat real quick? Because we may use
Yeah.
it. And I think it'd be good for anybody who just like cringed when I said the F word. Um, in most eating disorder treatment spaces, there is work being done to destigmatize the word fat, that it is
Mhm.
in the same category as tall or short. It is not less than, it is not worse than, and it is just a descriptor. So in case that jostled anybody listening or watching, I
Yeah.
want to say I'm sorry to jostle you, and you may hear it some more.
Yeah.
And that's okay. Like it might be some good desensitization for you because it's not bad to be fat. So
I love that. Yeah. And I much prefer the word fat over the O words. And I'm sure you know what I'm talking about. And I'm sure
uh-huh.
everybody else knows what I'm talking about.
Yeah, yeah. So okay, so we've got diabetes is not like a fat person problem. Diabetes is not caused by sugar.
Hmm.
Diabetes is not caused by being fat.
Hmm.
Um, what other myths are out there that people walking around just don't realize isn't
Yeah.
the
So
truth?
another big myth, I think, is that if diabetes is well controlled, that means weight loss is going to occur, right? So
Mhm.
this idea that like a smaller body or like a change in weight, a decrease in weight is an indication of better controlled diabetes. That's actually not true at all. So many people, when their blood glucose is poorly controlled, actually lose weight because the body is literally not absorbing nutrients, right? So
Right.
and sometimes when diabetes like glucose control improves, actually weight gain occurs, right? And so this happens, it's weight gain, weight loss, and everything in between, right? So that's
Mhm.
another, I think, big myth that like you know someone someone who has controlled blood glucose is going to be losing weight. That's actually just not true.
Yeah, and this might, I want to check in on the converse of that. Is it also a myth that if you lose weight, it solves your diabetes?
So the exact relationship there is not clear. So in other words, like, losing weight can decrease or I'm sorry, losing weight can increase insulin sensitivity.
Mhm.
And at the same time, like insulin resistance can make it harder for that to happen. So it's kind of a very the exact relationship there is not clear.
Okay, got it. Okay. Any other myths you can think of that should be
Well,
cleared
so
up?
so those were the big ones that I wanted to talk about. But another myth that I hear about a ton is this idea of good foods and bad foods.
Yes.
Yeah.
Which we have in general in the world. Um,
Mm,
but I think especially when you've got a diagnosis that is so heavily infiltrated by diet culture, it's it has a different, sorry for the pun, but like a different weight to it, right? Of like
mhm.
like if you don't have diabetes and there's a good food, bad food situation, it's already like you're already maybe grappling with it emotionally. But if you have diabetes and you're told this is a good food, bad food situation, you're grappling with it emotionally on a different level because it also means your health. And it
That's
also
right.
means like your like judgment of others for
Right.
either case, but certainly with diabetes.
Right, absolutely. And I think also there's so much anxiety that occurs like anytime you have a new health diagnosis, right? And I do think there's a lot of kind of fear mongering out there that basically like leads people to have these thoughts like if I eat this cake, I'm gonna have my foot amputated or,
Uh-huh.
like I think there's a lot of sort of unhelpful thinking that can come from this kind of good food, bad food
Mhm.
myth. And I completely agree with you. Like it feels very akin to disordered eating and disordered thinking that way.
Yeah. And I think maybe we can start with non-diabetic good food, bad food as a discussion to introduce people to.
Sure.
Um, and then talk about how that is similar and different with diabetes. Um, because I think probably most people listening, if you're not working with folks with eating disorders or you're not trained in working with folks with eating disorders, you might think, well, like, yeah, junk food, like we should not eat a ton of junk food.
Mhm.
Like kale is better than cake. Like have some kind of like obviously this more nutrient dense thing is
Yeah.
better than this thing that doesn't offer my body actual
Yeah.
nutrition.
Yeah.
And yeah, that's part of what we have to pull apart when we're working with folks with disordered eating or eating disorders.
Mm-hmm.
Because
Mm-hmm.
while it's true that something may be more nutrient dense, that doesn't mean it's a good food. And if something does not really give your body everything that it wants or needs and just happens to taste really good, that doesn't make it bad.
Absolutely.
It's like trying to call a person a good person or a bad person.
Right, exactly, exactly. And I love talking about this because it gives me a chance to like remind myself of my DBT training. And
Uh-huh.
one of the interventions I love in DBT is what's called the kernel of truth. And the kernel of truth that diet culture has kind of taken and run with is that some foods are more nutrient dense, some foods are less nutrient dense, right?
Mhm.
But I think what they've done is they've kind of taken that and run away with it and made it kind of toxic, right? Um,
Mhm.
and we need to eat with a lot of flexibility because there are real life limits. Like sometimes we have time to prepare, or buy a nutrient dense meal, and sometimes we don't.
Mhm.
Um,
And sometimes we
uh,
don't want to. Like it's also
right,
okay to just like love a cheeseburger that somebody
totally.
else would be like, "Oh."
Yeah.
Fries taste good. Are they doing a whole lot for like vitamins and minerals in my body? Not so much, but like they're doing a whole lot for my taste buds and my willingness and ability to feel pleasure.
Absolutely. And carbs also give us energy, right?
Hmm. Yeah.
And that's a really super important thing. Yeah, so I think that like starting to learn how to observe food without judgment is a super good step, for treating eating disorders and for coping with diabetes. That,
Yeah.
okay, this food does this for me and this food does this for me.
Hmm.
And I might want this and I might not, right? So like really getting away from these kind of moral judgments, good or bad. Like these are moral
Hmm.
judgments.
Right. Because how do you think about yourself if you quote unquote indulge in bad food?
Hmm.
All of a sudden, like you're bad too. Like there's a
Hmm.
guilt that gets associated with it that I see, like I see amongst people with eating disorders. I see even more amongst people with eating disorders, disordered eating, and diabetes on top of it, because then it's like you're already quote unquote bad for eating the food that's bad. And now you're also endangering your health, which makes you worse. Like there's a lot that people
Right.
take on
That's right.
that is all based on like kind of bullshit morality that doesn't actually exist.
I completely agree. I completely agree. And actually, so, if you Google like type 2 diabetes treatment, one of the first like 10 things that comes up is an article about 20 foods to avoid if you have type 2 diabetes, right? So
Mm-hmm.
like this is really it's ubiquitous, right? Like it's everywhere. These
Mm-hmm.
like kind of these ideas that like this is okay and this isn't.
Yeah. And it exists everywhere around us.
Hmm.
Like you said, it's ubiquitous. So it takes a
Hmm.
lot more energy to try to counter it
Hmm.
internally, especially if you're surrounded by people in that soup who are not trying to pull themselves out of the soup or don't know to pull themselves out of the soup. And they're like, oh, but should you be having cake? And they're maybe well-meaning. They're not trying to say necessarily anything about the way you look, but
Hmm.
they also have heard that sugar is like what causes diabetes or is terrible for diabetes, and they're wanting to make sure you're okay. So then it just like stirs into the cycle that can pull you back.
100%.
Um, and I think the idea that food is fuel is partly to blame. This like wellness culture, food is fuel. Like food is fuel, sure, like, and it's pleasure,
Yeah.
and it's community, and
Hmm.
it's can't just be one thing for us if we're
So
going to
many
have a
things.
balanced life.
Hmm. I completely agree. And another reason this sort of good food, bad food idea is so problematic is that there are so many things that impact how a food is sort of processed in the body of a person with diabetes or just anyone with a body, right?
Mhm.
Um, so just for example, like if I eat two pieces of white toast, white bread, that's going to have a certain impact on blood glucose. And if I eat two pieces of bread with butter, that's going to have a different impact. If I
Mhm.
eat two pieces of bread with avocado or peanut butter, that's going to have a different impact still. And if I eat two pieces of bread and then I go for a walk, like again, that's going to have a different impact. So it's super problematic to say this food's okay, this food isn't okay, right? Because
Exactly.
pairing when you pair carbs or sweets with protein, fat, and fiber, the body is much more able to kind of digest and handle the glucose that's coming in, if that
Mhm.
makes sense.
Absolutely. Yeah. Yeah. Which it's a nuance. We're in a culture that doesn't love a lot of nuance,
That's
just in
right.
general. And so
Yeah.
it's like a nuanced perspective on health instead of what I think many of us, myself included, would really love, just like a rule book of how to be healthy, and then I'd follow it. Like, just give it to me and I'll do it. I want
Right.
to be healthy. I want to live a long time and feel good. But there is no such rule book because all the experts disagree. And then you've got a lot of pseudo experts who come in and want to put their opinions in there that aren't based in any research. And then sometimes they're the loudest because they're the most charismatic. So
Right.
it gets messy. It just gets messy.
Yeah, it does.
Um, and I think as you're talking about knowing the impact of different foods and like in combination with one another and how your body processes that, um, I think when we're treating somebody with an eating disorder who doesn't have diabetes, we work towards not logging everything in a food diary, not like towards not paying such close attention. But I'm
Hmm.
guessing, especially for a new diabetes diagnosis, there might need to be some attention spent until they start to understand how to manage, like how that dry toast, which might have been a diet food for them at one point, maybe back in the low fat days, um, that dry toast might have been okay in their diet culture mind before, but now it really needs some avocado or peanut butter, you know?
Hmm.
Um,
Hmm.
how do you manage that with clients in like not obsessing over the food while they're learning how to do the food in a way that is healthy for them.
For sure, for sure. Yeah, that's a really great question. And one thing I really like to talk with clients about is whether or not continuous glucose monitoring is the best choice for them. So
Mm-hmm.
so when you use a continuous blood glucose monitor like the Dexcom or there's another one called the Libre, you basically what it does is it connects to your phone, and you basically have a 24-hour a day ability to like look, okay, where's my glucose? Where's my glucose? Where's my glucose? Right.
Mm-hmm.
And this can be tremendously helpful because it can help you start to learn about how does high blood sugar feel for me in my body? What does it feel
Yeah.
like? What does low blood sugar feel like for me? And what does it feel like when I'm just right in that sweet spot, right? So,
Mm-hmm.
so continuous, like I just want to be clear that like there's a place for it and it can be very, very valuable. And at the same time, it can create a lot of obsession, a lot of obsessive thinking. And so that's just one thing we talk about is like, okay, so can we plan to check it, 3 times a day or 4 times a day, but reduce, the kind of constant like check, 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 check. Where am I? Where am I? Where am I? Right.
Mm-hmm.
So that's one thing we talk about.
And I think about how so many people with eating disorders have OC features, if not OCD,
Mm-hmm.
right? And how that checking is
Mm-hmm.
such a part of their daily life in different ways often.
Mm-hmm. Mm-hmm.
Um, that I mean, like I personally have to be careful with numbers. I have an Aura ring and it will tell me like how I slept last night and what my resilience level is like and what my stress level was like. And I will sometimes go back and forth between my stress and my resilience levels like multiple times a day in a way that is like, what am I going to do about it? Like I'm making the same exact choices that I would be making if I didn't see those numbers.
Mm-hmm.
But I'm like, I want my resilience up. I want my stress down. And meanwhile, driving my resilience down and my stress up, right? Like it's counterproductive.
Mm-hmm.
And so I think for those of us who, as people, get really driven by numbers,
Yes.
it's easy to fall into this trap
Yeah.
of like checking and um, striving and wanting to do better and trying to get it all just right.
Absolutely. Absolutely. Yeah. And I think it's also really, really important to make sure you have a provider that's willing to like look at the numbers, but also look beyond the numbers. That's another, I
Mm-hmm.
think, really important piece is like,
Yeah.
do we have a team that you feel comfortable and safe with?
Yeah, which I'm guessing is probably hard to come by. I know from my just eating
Yeah.
disorder clients without
Yeah.
diabetes, it's hard to find a doctor who isn't a doctor who has nuance around weight and body size
Definitely.
and acceptance. Um, I'm guessing when you add another layer of medical providers who are in the soup with the rest of us, it can be really hard to find people who are not focused on the numbers that don't matter in with all the numbers that do.
Absolutely, absolutely. And um, I do think that physicians are often trained in this kind of very weight-centric model. And so it makes the, like you said, we're all in this kind of soup together, and it makes them it can make them hyper focus on numbers for sure. And I think you're exactly right that there's numbers that matter and numbers that don't, right, matter. And even the numbers that matter, I feel like we have to take with a grain of salt always.
Mm-hmm. Yeah. Yeah.
So just for example, so one of the most common measures that's used for people with diabetes is what's called the A1C, and the A1C tells us an average of blood glucose numbers over 3 months, right?
Mm-hmm.
And that's a great measure. It can tell us a lot, but it also can't tell us everything,
Mm-hmm.
which I think is really important.
Yeah. So how, like, what does it miss and how can that be tracked to give a broader picture?
Yeah, for sure. So great question. So one thing that really came to my mind when I was thinking about this, about like what does A1C give us and what does it not? So just for example, there are these medications that have come out, the GLP-1s, which I think show a ton of promise. And at the same time, they do have side effects. And, so just thinking about this, like a person's A1C could be like right where you want it to be at like a 5.5 or a 6. So for diabetics, we want A1C to be under 7. But if someone's having really bad side effects from one of those meds and their A1C is great, well, that's a problem, right?
Yeah.
So like we don't want to look only at the A1C and kind of get into the sort of tunnel vision place,
Hmm.
right? Um, but A1C also does not capture variability. So in other words, like someone can have a really good average blood glucose, but if they're swinging from like a 60 to a 250 or a 300 blood glucose, that's problematic. That's not great. So like I think it is
Hmm.
just really important to look at numbers and where can we utilize them and where should we, be less focused on them.
Yeah. And I'm curious, like with a range like that, like when you have swinging glucose levels, and that's not picked up by the A1C because that's all about averages, like going back to like stats classes back in
Exactly.
the day. So you've got your range, you've got your average. Um, like how does that get measured? Is that just self-report because they see it on their glucometer? Is that something that's able to be addressed at all if they don't self-report that?
Well, that's an excellent question, and I think that that's where, you really want to make sure you have a good team, like a doctor that's asking good questions, a dietitian that's asking good questions, and is not like kind of just looking and saying, okay, well, your A1C is fine, like we're done,
Hmm.
bye. Like,
Yeah.
and I think also just, yeah, I think it is a lot of self-report, helping people like tune in to how they're really feeling and like and helping them know that A1C is not everything
Hmm.
for
Yeah.
sure. And variability also. So, usually when someone gets their like blood drawn for an A1C, they also do test just glucose. So glucose in that moment, and that can also be a helpful measure.
Hmm. Yeah. I'm wondering about like the role of the therapist as a part of that team,
Hmm.
particularly if the client doesn't feel very supported by the other people on the team
Hmm.
and maybe isn't self-reporting. I'm thinking about clients with eating disorders, huge variability in their blood sugar levels.
Hmm.
Um, is that something that as the therapist, because you have releases, you just let your client know, like, I think it's important for your medical team to understand, how this is going? Is there ever pushback with that since they don't feel like their team gets it? Or how does that usually go?
Definitely. Yeah, definitely. So I think there is a lot of pushback because I think that all of this, all kind of the culture around diabetes care really induces a lot of shame for people, like
Hmm.
big time, big
Yeah.
time. And so I think it's super, I mean, so ideally people have doctors and professionals on their team that are, that are discouraging or, are really, observing without judgment and recognizing that like blood sugar can be all over the place for all kinds of reasons and it's not their fault, right?
Yeah.
So I think, helping them like create a team that they feel pretty good in is a really important thing. But also if they don't have a team they feel really good with, we have some options, right?
Hmm.
Like so for example, like can I call your doctor and maybe try to help them understand how you're
Hmm.
feeling? Or, can you and I write out some notes on things you want to say, right? Things like that. Or, another good example is that, pretty often when you go to the doctor, the first thing they do is weigh you. And so helping people feel empowered to decline being weighed, and
Hmm.
different things they can say to do that.
Yeah. I'm curious. I'm thinking, so I have a nephew with diabetes. He
Hmm.
was diagnosed as, I think he was 11 months old.
Oh,
Type 1. I'm so glad they caught it when they did. He's a
absolutely.
teenager now. He's amazing. And I think about the blood sugar variability he's struggled with. I mean, really his whole life. I think it's fairly level now, but kids with diabetes, it's just all over the place. And
Yeah.
I'm curious about the response to if there's a difference in the response from providers with clients or patients with type 1 diabetes versus type 2, because I think culturally there's a difference in how we treat and see people with type 2 diabetes than with type 1.
Definitely. Yeah. So I've worked with many people with type 1 diabetes as well. And unfortunately, I think that there's still quite a bit of shame. Like I
Mhm.
think, I'm thinking about clients who I've worked with, who've talked about like going in to see their endocrinologist and, and kind of like looking at the numbers and looking at what they ate and just being like, okay, well, here's what you need to do differently. And,
Mhm.
and it's not a direct kind of shaming that is occurring. It's a more indirect kind of like, well, what do you need to do differently? Right.
Mhm.
So I think that a lot of shame can really come up, and I think type 1 is just it's. I think the impact of type 1 is really substantial, and it's really, really difficult.
Mhm. Yeah. I just think about how, like, if as a culture we see people with usually type 2 diabetes as people like it was caused by being fat or it was caused by eating too much sugar. Like,
Right.
I can see this idea of like you
Right.
brought this on yourself kind of judgment
Exactly.
that, because I've known a lot of people with both types of diabetes in my life. And I think about how some of the people with type 1, when they say, because I usually meet them as adults, when they say like, oh, I have type 1 diabetes, like there's a distinction that they want to make clear.
Yes.
Um, and and I don't know if that's about like the severity of the disease or if that's about I didn't cause this myself, don't think that kind of thing, that there's a protection or a protectiveness that may be at play. Um,
I
I don't know,
hope
just
so. Yeah, I hope there is, because like I don't want anyone, type 1, type 2, I don't want anyone feeling
right,
shame or feeling like it was their fault, because it's just not.
right. And I think that our culture can treat people as if it's their fault in a way that,
Hmm.
like, as a therapist, if you've got some of your own biases and a client mentions, like, maybe you're not an eating disorder therapist, you're, helping them with anxiety or depression or something, and they mention that they have diabetes and they're fat, or they just talked about the like ice cream they had last night or whatever, to note your own bias, to realize that it's probably not rooted in peer-reviewed journal articles that you read, that it's based on like what's out in the ether, and to make sure that you work on that in order to be fully there for your client.
Definitely, definitely. I think that's hugely important. Uh, just really wanting to make sure, yeah, therapists do like unpack their own bias and, and make sure they're not bringing up, oh yeah, I just started this new diet or,
Oof. Yeah.
stuff like that. Yeah,
Yeah, I would love, I think my job, my field of eating disorders would be so, it would benefit so greatly if every single therapist in the world would stop recommending different diets to their clients. The
agreed.
number of people that have recommended different diets to their client, like, it boggles my mind. I know it's well-meaning. Like, I trust them that they were trying to be helpful, but it's like extraordinarily not helpful and outside your scope. So just
Absolutely.
gonna drop that here in the middle of the CE. Please never do that again. If you've done it before, it's okay. You know better now. Um,
Definitely.
yeah.
Definitely. And I think there's other things therapists can do, so just for example, one thing I think is really, really important is that we never, ever, ever comment on a client's body ever.
Yes.
Like whether we
Yes.
think they've like lost weight and they look great, or, they've gained weight and, we want to try to find out what's going on with that. We always want to be asking questions about how's your relationship with food and how are you
Hmm.
doing? And, and really make sure we're not ever commenting on a client's body.
Right. Right. And I've gotten to the point where I don't even comment on like hair or, anything. Like, I'll say if somebody comes in and it is the truth, I'll be like, you are vibrant today.
I love
Like, what's going on? I want to hear all about it. But otherwise, yeah, I try to just not make any comments about appearance because it can be interpreted in ways we absolutely don't mean it. And,
absolutely.
like, I
Absolutely.
I know like a lot of I had some clients who got really triggered when a provider told them they looked healthy after they'd been through a refeeding process, which is where you
Mm-hmm.
have to gain a bunch of weight because you were at an unhealthy low weight.
Mm-hmm.
And to be told healthy was the same exact thing to them as being told they looked fat.
Yep.
So,
Yep. I think you have to really empathize and really think about how a person with any kind of body image issues, which is so many of us,
yeah.
how they're gonna hear what you're saying. And that's also not to say that there are, therapists out there are great and mean really well for sure,
Mm-hmm.
right? And I think it's really important to think about how those words can impact our clients.
Yeah. Yeah. And I generally recommend if a therapist who is not trained and experienced in eating disorders gets a client who discloses an eating disorder or something you think might be an eating disorder, unless you're very interested in learning and doing a bunch of training and getting weekly supervision, I would highly recommend referring that person out for eating disorder, like to an eating disorder specialist.
Definitely.
And I would say if you suspect they have an eating disorder and they have diabetes, like it's even more important because there's also some potential health risks depending on what their eating disorder is looking like.
Definitely.
Eating disorders are already the second most lethal mental health diagnosis.
That's
And
right.
you add diabetes to it and potentially uncontrolled blood sugar and, a client doing the best they can, but they're either binging or restricting or purging. Like it fucks up your system enough
Mm-hmm.
that when you
Mm-hmm.
have the kinds of needs that somebody with diabetes does for more stability across blood sugar, it can be really
Mm-hmm.
scary.
Mm-hmm.
So,
Definitely, definitely. And actually, I was just reading about this, about how weight cycling can make blood glucose really difficult to manage, or the impact of weight cycling on blood glucose is substantial.
mhm. Yeah. And weight cycling, for those of you who don't know, is like yo-yo dieting is how you
Yes,
might have thought of it
exactly.
before. Like
Exactly.
you're on a diet, you're off a diet, you're on a diet, you're off a diet. Your relationship to food is consistently unhealthy, probably, but the way that you are going about trying to lose weight
Right.
um, differs.
Definitely.
Or or you can keep doing the same diet and then because your body doesn't want to be at that weight, it goes back, it resets to where it wants and needs to be healthy.
Right.
Um,
Exactly.
yeah.
Yeah, and I'm glad you're mentioning, set point. I think that's a super, super important concept for really for everyone to know about, this idea that your body will do whatever it can to kind of bring itself back to that place where it's comfortable, whether that means, changing your metabolism a little bit, or, whatever it needs to do to kind of make sure it stays where it wants to.
Yeah. Yeah. There's a range there for each of us, and it takes some pretty extraordinary effort to get beyond that range either way.
Mm-hmm. Mm-hmm.
And if you can make peace with your set point range, then your life will be much easier. But that's
Agreed.
a lot easier said than done.
Yes, for sure, for sure. Yeah. But no, I appreciate so much that you referring to kind of the nuances of everything, right? Because I really feel like that's just such an important thing to keep in mind, is that this is all very nuanced stuff.
Yeah. Yeah, it really is. And it's there are some tenets like set point that are going to be true across clients, but there are
Mhm.
also going to be some things that are really different from client
Right,
to client that
right.
we need to be aware of and we need to continue to check in with. Um, yeah, yeah.
Yeah, all really important stuff.
We've talked some about like blood sugar control, and
Mhm.
whenever I hear or say the word control, there's the eating disorder therapist in me kind of blanches. Like I'm like, oh, control. No, no, no.
Yeah,
We got to stop striving for control. But
yeah,
it is important to have some balance or some control. We
definitely.
can say control over
Yeah,
blood sugar because it's a health thing.
yeah,
And there's some problematic advice out there about how to find that control, and it can really align with disordered eating.
definitely,
Can
definitely.
we talk about that some?
Absolutely. Yeah. And something that popped into my mind immediately was I do love this idea of when I talk to clients about their relationships with food, I really love for them to try to think of themselves as in charge, but not in control.
Hmm.
And that's something I heard about. I believe her name is Judith Metz. She talked about this in a training I took, and I just love that idea of like taking away this idea of control and changing it to in charge. I think that's just a
Hmm.
really helpful reframe right there.
Yeah.
But yeah, so I mean, I think that diet culture talks a lot about, perfectionism and, really like over control, right?
Hmm.
Which is super problematic. And what happens for a person with diabetes when they try to kind of over control, is that they can, I think, get into this really obsessive place where they're, checking numbers over and over and over. Or being very rigid and sort of inflexible about like what foods are okay and what foods aren't okay. And I think really what that can do is and put us into what's called last meal syndrome, which means, okay, I can have this right now, but I can't ever have it again. So I'm gonna have all of it. Right. So if
Hmm.
I'm not allowed to have ice cream or cake, I'm going to kind of go on I might start binging because I feel like this food is not available to me, right? And I think that, the screw it mentality can also lead us to sort of be like, I'm not going to show up to my doctor appointment. And, I'm not going to monitor my glucose anymore. And I'm not going to try to move my body in a way that feels good. And so I think that perfectionism can get super, I think the impact of that can be really, really significant.
Hmm. Yeah. It's interesting because I think about like, that the example of that in school or something would be procrastination
Hmm.
or giving up or whatever, despite the fact that that's all coming from
Hmm.
perfectionism. And it's scary. It's a lot scarier when it's your health to just give
Hmm.
up. But I also can understand, especially if you're new to trying to regulate or take control of your blood sugar. Um, or you're in charge of your blood sugar. I'm gonna use that from now on. If you're new to it and it's variable and you're trying to figure it out, like none of us like to keep doing something we suck at. And
Yeah.
if you feel like I am not good at this, like whatever it's going to be, what it's going to be, after a period of time of it not going the way that you'd hoped, there are some real repercussions for your future with that.
Hmm.
Versus coming from this place of like self-acceptance and kindness to yourself of like, yeah, I've never ever had to do this before. It makes sense that like it's all over the place. I haven't figured it out. I've never flown a plane before and I wouldn't expect myself to be able to do it in a week, Like, and with the constant variables of each food and what it's combined with, it's going to be metabolized differently in your body.
Hmm.
Like it's
Hmm.
not like you can just get an ongoing hold of it perfectly all the time. It's just not
Hmm.
possible.
Hmm. Hmm. I completely agree. And something that I really was excited when I learned about this is that there's actually no statistically significant differences in health outcomes for people who maintain blood glucose kind of control in range
Uh-huh.
70 to 80% of the time and above 80%. So basically,
Wow.
everybody over 70% has pretty much the same health outcomes for people with type 2 diabetes. And so this idea that we're supposed to try to stay in range all the time, it's not true. That's
I
not
love that. You can have a C
true.
plus. It's great.
Exactly. And I think people come in, it's sort of like, I want to get an A in therapy. I want to get an A in therapy. And they're always so disappointed. I'm like, you can't get an A in therapy. It doesn't work that way. Like,
Hmm.
we don't really want people getting an A in blood glucose control either.
Right, because that means you're spending so much time and energy, wasted time and energy, like obsessiveness
Yes.
ultimately. Like that
Yes, exactly.
to get in like the 90th percentile or above, there's probably a lot of control going on
Absolutely.
and control with food to that level never goes well. Our well-being.
Absolutely. Absolutely. And I think it's also really, really important to note that like many things can affect blood glucose. So, so just for example, poor sleep can have a
Mhm.
huge impact on blood glucose. Just being sick with a cold or with COVID or with pneumonia, huge impact, right? And so can stress.
Mhm.
So like
Right.
many things affect like where blood sugar is.
Right. And thinking about like trying to achieve perfection with your blood sugar is going to cause you stress because it takes an exorbitant amount of work to get in that 90 plus percentile.
Right.
Um,
Exactly.
and I also wonder clinically, like, what are they missing out on in their life if they're up there?
Absolutely. Absolutely. Yeah. Like, I mean, nobody, well, at least I know I don't ever want to not have birthday cake.
Right.
I don't want anyone else to not have birthday cake either.
Right. And I think about like people in their early 20s, right? Like I want them to go out with their friends. Like maybe
Absolutely.
don't shotgun beers, but like go out, like maybe risk getting a little bit less sleep.
Mhm.
Maybe have L beer, and do what you can to accommodate that and maybe eat some nuts on the side. I don't know. But to have some, like to be your age, to have some fun. This is something I think about from my nephew who, when he goes off to college in a few years, like I want him to have the full experience. And I think his parents have
Mhm.
done a really beautiful job of not expecting perfection.
That's amazing.
And so he's had that modeled for him his whole life, like good enough is good enough with his
That's
blood sugar.
great.
Yeah,
That's so
yeah.
great. The other thing that's really, really cool is that diabetes technology has also advanced just
Mm.
exponentially. So, so the medications we have, the tools we have to treat it are just, it's just really, really cool to see how medicine
Hmm.
has advanced that way.
Yeah. Um, I'm thinking about like just the tool, like like blood sugar testing. I'm thinking about do people with type 2 get insulin sometimes?
Yeah, sometimes it depends on the severity.
Hmm. And so, yeah, just thinking about old school insulin back from when I was a kid, and I had a friend who had to like get out a syringe and like inject herself with insulin, whereas like my nephew, it just like goes right into his body when it senses it needs it.
It's so
Because he's
cool.
got that, why am I blanking on the name? But like basically that little port that they move around his body. So um it doesn't, so that there is some automation to it almost,
Hmm.
right? Like
Hmm.
it doesn't have to be all on you all the time.
Yeah.
Um, you can be responsible, you can be in charge of it, but it doesn't have to be a part-time job
Yeah,
to make sure that
exactly.
you're okay.
Exactly. And I think one of the reasons I mentioned that is that, it is a lifelong thing,
Hmm.
and I think that that makes it even that much more important to cope with it in a way that is flexible and sustainable and not over controlled.
Yes. Yeah, that's a really good point. That I guess I can also imagine like our typical eating disorder client gets diagnosed and then they want to do it perfectly. And they try to do it
Hmm.
also perfectly at first, and it's not sustainable. It
Mm-mm.
also doesn't really work.
Mm-mm.
And it
Mm-mm.
certainly doesn't work without incredible rigidity.
Definitely.
Um, and I mean, I can see it also being a good lesson. Like I'm imagining what many of my more rigid clients would do is like, okay, well, in order to manage this, I'm going to eat the same exact foods every single day. I'm gonna like they're gonna be like the right foods with quotation marks. They're
Hmm.
gonna be doctor approved, and I'm just gonna eat like that for the rest of my life.
Hmm.
But then they get less sleep one night because they're ruminating about something, or they've got an exam or a big presentation at work and their stress levels go up,
Yeah.
or they fall down and break their ankle, or they get a cold, and it's like you can't. It's a great example of like even if you're doing everything quote unquote right, you cannot control anything.
That's right. That's right. That's right. What I really notice, thinking about this and talking about this is, how much what I want my eating disorder clients to know is really aligned with what I think people with diabetes should know, is that we're
Hmm.
looking for flexibility, we're looking for sustainability, and we are looking for good health outcomes, and we're recognizing that like there are factors not in our control.
Right, right. And I think like the population of folks with eating disorders really dig control. Like it sounds great. I would love to have ultimate control. Let's be real. It would be wonderful. But I had to, I learned the hard lessons that like the harder I try, the worse it gets. So
Absolutely.
like there is no absolute control that's gonna be, period.
Absolutely.
Um,
I think that, that also brings up more kind of DBT and kind of ideas that are centered around, Buddhism, that like letting go of control can be this ultimately very freeing thing. It can feel
mhm,
really good to say, I'm going to do the best I can and like I'm going to let go of the rest.
mhm, absolutely. And I think about like our clients with different backgrounds and how important that control can feel to them and
Hmm.
how much like empathy we need to bring to those conversations when like all of us who have been through this work know it's easier said than done.
Definitely.
And relinquishing the semblance of control feels like there's a grief process. There's a feeling of like there's this like everything is going to fall apart if I don't have everything in a stranglehold. Um, there's a lot of fear. And then
Hmm.
there's shame when things
Hmm.
don't go according to plan, like as you're letting go of control.
Right. Right.
Because it would be easier for us as therapists and for our clients is if as they let go of control, everything got better. But that's not real life, and that's not what happens. Some things get better, some things get worse. And it's hard for them to maintain those changes, whether it's managing their diabetes a little looser, holding it looser,
Yeah.
or not restricting or not binging and trying the other things that have been working to prevent that.
Hmm.
Um,
Hmm.
or just not like bossing around their partners, like whatever it looks like to try to have control. Um, it's messy work.
Hmm.
And
Hmm.
there's so much beauty and freedom in getting to the other side, but it's hard to get there.
Agreed. Agreed for sure. And it's pain, it could be, I think, really painful for sure
Hmm.
to kind of be in that process of getting to the other side, I think can be very, very, yeah, very hard, just like you said.
Hmm. I think about how if the therapist hasn't done that work, it's even harder because you're going to try to control or force the positive outcome so that the client gets what they ultimately want and need. Um, it's hard to watch somebody that you've grown to care about suffer,
Definitely.
and especially suffer because of support that, or not the support, but because of the changes they've made with your support.
Hmm.
Um, but
Hmm.
it's a part of that process that has to happen in order for them to really be free.
Hmm. Hmm. Like this idea of like kind of, is it a good kind of hard or a bad kind of hard, right?
Yeah,
Like
I love that.
good
Yeah.
good hard, feels bad, but like, or it might feel bad, but ultimately like we're getting to a better place because we're letting ourselves kind of, stop avoiding and kind of live in the gray.
Hmm. Yeah. Yeah. And I think about like with your niche of OCD and eating disorders, like there's even less tolerance for the gray amongst your clients.
Hmm.
Um,
Hmm.
and you add diabetes onto that, and it's like they just got given a lot of gray that they can't get out of.
Right, exactly. And I think it's a beautiful place, I think, to use, DBT interventions and to
Hmm.
to really look at like the dialectics and sort of this idea that there's room for all of it. Like there's
Hmm.
room to say this feels really hard and I can do hard things, right? And there's room to say this is not my fault and it is my responsibility, right? And I
Hmm.
think that's like actually that's actually a perfect example of like a way I might use DBT in counseling someone with an eating disorder or with diabetes or both, right? Like it's not your fault, but you still have to take the responsibility to intervene and take care of yourself.
Yeah, absolutely. Yeah, I'm wondering about like other DBT interventions
Hmm.
that are helpful, particularly for folks with eating disorders and diabetes. Like, how do you use DBT to really support them?
Yeah, that's a great question. One of probably my all-time favorite DBT skill, and I love them all, but my
Uh-huh.
all-time favorite DBT skill is Wise Mind.
Mhm.
And Wise Mind is really, it's all about the gray. It's about looking at, okay, what are my emotions saying and what are the facts saying here? And then trying to kind of find, the intersection or the place that they kind of overlap and ask yourself, like, what's the big picture here? Like, I don't want to go to my appointment with my endocrinologist, but big picture, showing up to this appointment is probably a really good thing for me to do for my health.
Mhm.
Yeah, so
Yeah.
it's kind of one of my favorite interventions.
Uh-huh. Yeah. And I love that because I love Wise Mind too, because it doesn't like denigrate the urge or the
Yes.
desire to not do the Wise Mind thing. Like it's just like, yeah, of course that exists. Like nobody wants to go to the doctor,
Right. Right.
especially if there's fear that you're going to be shamed or, like there are a million reasons for us to not go to the doctor. And it's a wonderful part of taking great care of yourself, which is your responsibility.
Definitely, definitely. Right, right. And, ideally you have a doctor that, has an understanding of this sort of like fault versus responsibility piece and,
Mhm.
is really able to say, like, we can figure this out. We just have to work together.
Yeah.
And that's what I really, really love when I hear physicians say that like, I'm part of your team, like, and this is totally manageable as long as we work together. Like, that's what I
Mhm.
really love to hear.
Yeah. Yeah. I think there's a real, when they're able to partner with their doctor, it makes it all feel safer for clients because they know they feel cared about. Um, and I do genuinely believe most doctors are doing the best they can, that they
Absolutely.
are really wanting to help people. And I also know that many doctors are overworked and
Yes,
managed care has made it such that they cannot spend the kind of time that they want to with their patients.
absolutely.
And the time that really helps them get to know their patients in a way that they can see them, like really see them and hear them.
Definitely.
Because I certainly could not do 15-minute therapy appointments.
Yeah.
Like I would not be effective and I would miss things and I might, it'd be supportive.
Yes.
They maybe feel nice by the end of the 15 minutes if possible, but
Right.
it's it's complex and it's nobody's out to get anybody, I don't think. I think we're all just like culturally, I think we're misinformed
Hmm.
um, from a healthcare structure where the supporters aren't able to do the support that they were trained to do and want to do. Um,
Absolutely.
and that creates a divide often between patients and their providers.
Absolutely. And I think it's another really like beautiful place to use sort of dialectical thinking, right? That like we know physicians are, they're rushed, they're overworked, and they're doing the best they can, and we want them to do better, right? Like, and I
Mm-hmm.
think I think we definitely can hold space for all of those things to be true. And I also think that the therapist can be a great kind of advocate or sort of a tool in that relationship. Like, can I help you know what to say to advocate for yourself with your doctor? Or can I call your doctor myself and maybe talk this out a little bit?
Yeah.
So I think that that's another really cool thing, the way that like the therapist can also kind of step in to help support that relationship.
Yeah, absolutely. And it can also be a good referral source
For
because if
sure.
this, like all healthcare is mental health care. Ultimately, like
Absolutely.
any anybody who wants to go, anybody who wants a patient to make a change, any provider, the patient will not make a change depending on their mental health care, or they will depending on their mental health care. You know, like if they have the internal resources to make these changes, that's what all doctors want. That's what all providers want, is for people to be well.
Definitely.
And so if you become the person in that doctor's mind who gets it, who is supporting them and helping them make those changes, then you'll probably end up getting a lot of referrals from that doctor. So be careful. And have your own referrals on hand for when you're full. But it's a good thing to form these relationships with medical providers. Sometimes, you know, I've had the opportunity to talk to primary care providers who just didn't, you know, they didn't get any real training in eating disorders. And they got very little training on nutrition, and they didn't get any training on health at every size. Right. And so there have been opportunities to educate some of the doctors that I now work with, or have worked with in the past.
I love that. I also, sorry.
No, go ahead.
Oh, I was just going to say, I also think having a HAES aligned dietitian on board can help a lot. And
absolutely.
And they also, you know, I think that therapists and dietitians, you know, we keep kind of a running list in our minds of like, oh, we like this doctor, like this is the one to go to.
Yeah. Yeah. Literally one here where I live.
Yeah.
Yeah. And for folks who are not familiar, HAES stands for Health at Every Size. And it is a movement, very well researched movement. So much data that shows that health and weight are not correlated, except at like extreme extremes, right? Like if you're on extremes, and not the extreme you might be thinking, but even more, then sure. But that what the data shows is that the socioeconomic status, for instance, is far more predictive of health than weight is. And sometimes that is correlated with weight. But there are just these, weight has become this focus that the data doesn't actually support when you dig a little deeper.
Absolutely. Absolutely. And I think you summed that up so beautifully, that like there's a lot of kind of ideas out there that the data doesn't support when you kind of like look under the like you peek under the cover a little bit and you're like, oh, there's this whole flood of information here. Like I don't have to be in control of my blood sugar 90% of the time to have a good health outcome.
Right. Right. Yeah. And that one is so, I love that so much. It makes me think of, I was at a continuing ed for, it was like an attachment theory continuing ed. And it was specifically for I don't know that it was for parents, but it was talking about attachment with kids, and how, basically we spend like 30% of our time doing a great job and being really connected, and 30% of our time really messing up as parents, and 30% of our time repairing. And if you've got that dynamic, you're good to go. And I was expecting 90% of the time to be like the perfect parent, and messing up and repairing 5% of the time each. And it was such a relief to me. And I was like, okay, like I'm not screwing my kids up. I mean, maybe some, but not significantly.
I think I felt a little anxiety leave my body when you said that.
Yes, it's amazing. I mean, I felt so free, and I can imagine like if I had diabetes and I heard that like 70% it does not have significantly different outcomes than 98%, and I'd be like, hell yeah.
Yeah,
I'm gonna go have some cake.
Yeah, I love it. I love it. And then that's the thing, right? Like diabetes, it's really, really manageable. It really is. And when I got diagnosed with it, I felt so scared. I felt so scared and so sad. And I'm just really, and at the same time, like now I see I'm really happy in a way that I have it, because it's allowed me to learn a ton more and support my clients more effectively.
Absolutely. Absolutely. I'm trying to think of anything else. Is there anything else that you would really love therapists who maybe they're eating disorder therapists, but don't work with folks with diabetes, or maybe they're just like an average therapist, like generalist out there. what do you
Mhm.
really want them to know about working with clients with eating disorders and diabetes?
So I actually made a little list here.
Ooh, I love a
I
list.
I want clients to, or I want therapists and clients to know is that regardless of size, there are a couple things that are really good for people with diabetes and eating disorders to do. One is maintain a really good relationship with your provider. Whether that's an endocrinologist, a primary care physician, a therapist, a dietitian, or all of the above. Ideally, we've got all of the above, right? And if that provider causes you to feel shame about having diabetes, that's a problem. And you can try to get a new doctor, or you can educate them, or you can try to get your dietitian or therapist to help educate them. So we have options there. Drinking water and staying hydrated is also a super good thing for diabetes. Generally, monitoring blood glucose is also a really good thing for diabetics to do, but there are pros and cons to continuous blood glucose monitoring. Pairing carbs and sweets with fat, fiber, and protein is another really good thing to do. It just helps balance blood sugar. Eating regularly is another really good thing to do, and engaging in joyful movement. Also, just good for you in general, but it also helps increase insulin sensitivity, which
Hmm.
is, the opposite of insulin resistance, which is kind of what diabetes is all about. So yes,
Yeah.
I think those are just some good, Hays aligned, tips and habits that, we can encourage our clients to engage in.
Hmm. And we haven't talked a whole lot about movement, like
Hmm.
joyful movement or movement you enjoy. These are things that have been said today,
Hmm.
but
Hmm.
I think it's such an important distinction from exercise or working out in the way that we often think about exercise and working out.
Absolutely. Absolutely. And one of my favorite ways to help people access this like concept of joyful movement is to ask them, what did they really love to do as a little kid? Like, did
Hmm.
they like to ride their bike? Did they like to, I don't know, get out and help in the garden? Did they like to roller skate, or like whatever the thing is? Like, let's
Hmm.
bring you back to that place where moving your body was just fun. It
Yeah.
just felt fun and good.
Yeah. And I think about how in our culture, there's kind of like a working up to earn eating. There's a sense of like,
Mm-hmm.
yeah, and that working out is so often seen more from this lens of how to look, like how to reform your body and the way that you want it to look and things like that. And that can have a lot of people. Well, we know that when people go to the gym because they want to change the way their body looks, they stop going much earlier than people who are going for mental health benefits, are going because they want to be able to run around in the yard with their kid, like the myriad of other reasons to exercise.
Yes, and there's
Um,
so many. Yeah.
yeah. And like I'm real big right now on lifting heavy weights because I want my bone density to be like I want my DEXA scan when I'm 70. I want them to be like, hot damn, like um and while I have found that there are certain things that I don't like doing that I'm just not going to do. I'm not going to make myself do them to get that DEXA scan because there are other things I do like doing that yield the same results.
Absolutely. And I think if movement feels punishing, that's a real red flag for
Mhm.
sure. Like we don't want it to feel punishing.
No, absolutely not. It's like if I think about that dread, there are times I don't want to do it. Once I'm doing it, if I do it anyway, I'm happy that I'm doing it. And if then I feel great after I've done it.
Mm.
That if you're like you don't want to do it, you hate it while you're doing it, and then inevitably you'll probably feel good after you do it because that's how endorphins work. But if you're hating the process, like if you hate running and you're making yourself run, dear God, there's so many other ways to get
Yeah,
cardio, to move your body, to have fun, to take great care of your heart, and ultimately much better care of your joints. Um, but if you love running, please keep doing it. Like
absolutely.
do what feels great. It's really important, not just for our mental health and our physical health, but for like our relationship to our bodies.
Definitely. Definitely.
Ah, well, Kate, thank you so much for
Yeah,
talking with us today. I really
thank you
appreciate it.
too. Yeah, thank you.
Yeah. And I hope that people feel more informed, more supported. Are there any resources that you want to point people to that they want to learn more?
Yeah, that's a great question. And unfortunately, there's not a whole lot of people talking about this.
Hmm.
There is a book called Eat What You Love with Diabetes that I like. And
Hmm.
then there's another one called Weight Neutral Support for Diabetes, which I also really like.
Hmm.
But I think that one of the reasons I wanted to talk about this is I think we need more people to be talking about this.
Absolutely. Absolutely. Well, thank you very much, and I hope to see you
You.
soon.
Thanks so much.
I hope that broadened your clinical horizons. Head over to notboringces.com to get your CE credit. Want to have a not boring conversation with me about your clinical area of expertise? You can apply there too. If you like this conversation, leave us a 5-star review, tell a friend, and be sure to subscribe for future conversations.